So welcome everyone. Thank you for joining us to our first CPH seminar series. So before we start, I'd like to just basically dedicate these to Dr. Helen Watts, who was our CPH manager for many years, who unfortunately passed away very recently with aggressive cancer. And I think it just highlights the importance of public health and why we're all here today. So I'd just like to make sure we acknowledge that at the very start. So moving on, as I say, it's the first CPH seminar series, and we'll welcome Dr. Joyce Coker, Richard Milne, and Jonathan Goodman. So I'll pass it right over.
So hi everybody. So this is a talk in three acts. So myself, Jonathan, Joyce. There is a kind of thread that runs through them of an interest in what's the place of public trust in understanding how we innovate and practice healthcare in general and health innovation. And so we're going to start from this kind of broad focus on healthcare institutions. We're going to rapidly go into, I think, conversations around health data, which is something that I and Jonathan have worked on. And then Joyce is going to have broadened us back out again into thinking about situating these kind of conversations around health data in a wider context of trust in healthcare. There we go. All right. And so I suppose this is kind of so my entry into this. So I work between sociology and bioethics, and have worked for a long time around data, and particularly health data and genomic data. The work that I'm going to be talking about here is work that I did when I was at the university and at the Wellcome Sanger Institute. I'm now based at RAND Europe, which is but also based in Cambridge, but it's not, this isn't RAND work that I'm discussing. So when we think about health data, questions of public trust rapidly come to the fore. So around 10, 12 years ago, there was the care.data case where one of the first efforts to try to standardize, bring together general practice data and share it for secondary purposes, which kind of was rapidly rolled back following a kind of public and practitioner backlash of sorts. And so that when the House of Lords in 2018 was thinking about how does the UK develop and implement AI systems, it emphasized the importance of public trust. Public trust over the safe and secure use of data is paramount to the successful widespread deployment of AI, and there's no better case of that than health data. And this importance of public trust has this recognition of the importance of public trust persists. So we are now currently in the early stages of the implementation of the Health Data Research Service, which is part of the government's 10-year plan to enable widespread secondary use of data from the health system, from large-scale research projects like Biobank, and to provide a kind of single access point to this data. And so this is from a commentary that was published in the BMJ a couple of weeks ago by Andrew Morris, who's the head of HDR Health Data Research UK, and Ian Buchan from the University of Liverpool, emphasizing that the kind of implementation of this service isn't only about data and it's not only about technology, but it's about people, it's about public trust, because these are their data. So what do we know about public trust? We've got a range of kind of studies that show that generally people are relatively trusting of certain types of institutions with their health data, GP practices, NHS hospitals. So the NHS generally is fairly trusted, and then you have this kind of sliding scale whereby people trust other institutions involved in care a bit less than the NHS. They trust universities a bit less than that. They trust pharmaceutical companies less than that. And then by the time you get to health technology companies and the government, people are significantly more untrusting than they are trusting. So this is from research from 2024 from the Health Foundation. We've similarly done work around genomic data a couple of years ago and finding this kind of same pattern. If you've got your own doctor, you will trust them with your data, and after that, everybody else kind of slides off. And then particularly if they're overseas, they slide off even more. So this kind of willingness to share data for research purposes. And this matters because, as analysis that Jonathan did recently showed, basically your level of trust, how much you trust the NHS, will shape not only your willingness to share that data, but your willingness to kind of generate that data in the first place. So this was around somebody's willingness to use wearables or similar things in order to kind of generate data related to their health. Essentially, the more trusting somebody is, the more trust somebody has in the NHS, the more willing they are to use a data for health, a used device for health tracking. So trust is both, important, varied, and consequential. But one of the things we want to do in this conversation, I think, is marry up some of this, empirical stuff that we know about who trusts, where do they trust, how much do they trust, with a bit of a thinking about, like, well, what's the problem here? Like, what is it that we're talking about when we talk about trust? And so in a kind of, at a conceptual level, trust is essentially this three-part relationship. So A trusts B to do X, or in domain X. So I might trust my doctor to deliver me care, to make me better. I might not trust my doctor in other domains. Like, I probably don't trust them to do my plumbing. So trust isn't a kind of generalized, I don't trust my doctor for everything. I trust my doctor in relation to my data. But there's also something about the nature of that relationship which is distinctive, that it's not the same as, me relying on this computer to work. There's a kind of, to the extent that they do work, but it's more, but there is a kind of, there's something about trust which makes it more than what philosophers call mere reliance, acting on the supposition that something will just do what you expect it to do. It doesn't make sense to talk about trusting a light switch or something. It just does what you're expecting it to do, or a shelf. And that what that something else is debated, but that essentially there's a kind of core of that it's related to a vulnerability, that you usually put trust in a position in which you stand to lose something, and in which you're uncertain. So where you don't necessarily know. If I press the light switch, I'm pretty certain that the light will come on. Again, in an ideal situation. But in trust, when you place trust in somebody, you don't know what's going to happen there. You have to have some element of uncertainty. And that means you need to have reasons, whether they are kind of rational reasons or emotional reasons, to feel that you can trust somebody in that domain. Whether that's because they're certified or because you've got experience of them. And we'll come back to that in a bit. And so that's why Honora O'Neill, writing in 2018, pointed out that what we end up with at the moment is these kind of, we have information about people's generic attitudes of trust or mistrust. So we know that people, 68% of people trust their GP. But what we don't know is whether those attitudes are well-placed or ill-placed. You want to place your trust in somebody who is trustworthy. And we want to avoid placing trust in people who aren't trustworthy. And I think that's one of the things that we're going to pick up through these three talks, is this problem of trustworthiness. So we're going to move from talking about public trust as a problem to talking about trustworthiness as a problem, which places less of the emphasis on the public and more on the individuals and institutions who we expect to be trustworthy. And it creates two questions. So for us who are placing trust, how do we know who the trustworthy are? How do we ensure that we're placing trust in the trustworthy and not in the untrustworthy? And for us, when we are acting as researchers or as any other form of trustee, when we know that we are trustworthy, when we have the qualities or characteristics and we do the things that we think a trustworthy person does, how can we be trusted? Because that doesn't necessarily translate. You can sit there being trustworthy with nobody trusting you. And this is a practical challenge for health data institutions. When we're trustworthy, how can we be trusted? So I'm going to hand over to Jonathan in a second to talk about this kind of first challenge of how can we know those who are trustworthy. Then I'm going to come back in and talk a bit about some qualitative work that we've done on how do we know, on kind of what does trustworthiness look like in practice. And then I'm going to hand over, and then, I'm going to hand back over to Joyce to talk about trustworthiness in context and some of the work that Joyce and Jonathan are planning going forwards as well. So Jonathan, with that, I will hand over to you. And
thank you. Thanks, Richard. So I get the easy job of talking about problems, which is much easier than talking about solutions, which unfortunately can be Joyce's job. But so for background, I'm an anthropologist by training. I studied human evolution. And I've always been interested in why is it that humans cooperate? Why do we trust each other? Going back over our evolutionary lineage, what did trust look like for most of our history? And what does that tell us about how we form trust in the modern environment? So in the evolutionary sciences, there's not a whole lot of discussion of trust. The vast majority of our history, 98% or so, we were living in camps of about 150 people, which corresponded, interestingly, to predictions around the size of the human neocortex. So Robin Dunbar, an evolutionary psychologist, ran an analysis showing that compared to other non-human primates, the human neocortex would predict that we have about 150 connections. And that's basically what we see in the hunter-gatherer and ethnographic literature. People would have roughly about 149, 150 connections over the whole course of their lives. And thinking about the fact that that made up the vast majority of our own past, the circumstances in which we all lived until the very recent present, that means that trust probably wasn't so important a quality or relationship over our history as it is today. If you could know pretty much everyone you were dealing with directly or indirectly, you wouldn't need to make these leaps of faith in terms of the relationships you were forming, going on a hunt, forming various kinds of partnerships, and so on. And so today, in the modern environment, where in a given week, we're probably interacting with as many people as we would have seen in our entire life in some cases over our evolutionary past. This problem of trust becomes really important, particularly when we're talking about the advent of digital technology, AI, misinformation, and so on. We're being fed with so much information on a daily basis. It can make knowing who to trust, how to place trust extremely difficult when relying solely on these psychological abilities that were formed under very different circumstances. We think that trust is essentially kind of a cognitive shortcut. When you meet someone, you are operating on a whole host of signals, various signals about their appearance, the way they speak, the way they dress, the way they look, and so on, that will determine whether you enter into a kind of agreement with them, whatever those circumstances are. And you have to rely on that. We all rely on that in every moment of our lives. And anthropologically, that's very interesting when you're asking questions about modern institutions when trust is consistently being eroded. We've called this, in our published work, the trustworthiness recognition problem, which Richard alluded to. If you have two individuals or two institutions, A and B, one is trustworthy, the other is not, what's to stop B, the not trustworthy individual or institution, using the exact same signals that A does, appearing exactly like A does, and communicating that information to the public? Members of the public have no way to tell the difference between the two signals and what the underlying qualities are. So trustworthiness in this case, what we're highlighting is that it's an underlying state. It is not readily observable. It is something that has to be demonstrated through means that distinguish A from B. Hence the trustworthiness recognition problem being quite significant. So the literature in biology and economics has shown over the last 50 years or so that what we need to employ to get around this problem is something called signaling theory. And the basic idea behind signaling theory is that honest signals, true signals that represent a person or institution's underlying state of trustworthiness or lack thereof, those signals need to be costly. They have to impose a cost on the signaler such that they can't just be replicated for nothing. You can't just say, trust me, because anyone can say that. You can't just speak or dress in a certain way, wear a lab coat. Anyone can do that. You need signals that have meaning that cannot readily be copied. And there's a host of really interesting papers in different environments, broadly outside healthcare, over the last 50 years or so that have showed this point repeatedly. So the book Streetwise, which I'd highly recommend by Diego Gambetta and Heather Hamill, two sociologists, Heather Hamill went around Belfast in New York City, interviewing taxi drivers, people who are consistently in a position of vulnerability. When someone gets into their taxi, they have to make a judgment about whether that person is A, going to pay their bill, or B, could even harm them, right? If you are driving a taxi around, particularly in areas where there's crime, you have to be able to learn how to rely on signals that tell you something about a potential patron. Or another study that was run by Alice Hitchings at King's College showed that in digital environments like Telegram, where you have cyber criminals, we're not going to be able to rely on traditional signals that will show whether someone is trustworthiness when in an environment like cybercrime. People rely on information displayed, knowledge about the cybercrime economy, signals that, for example, undercover police wouldn't be able to replicate in order to choose who's trustworthy versus who is not. So one study that I'll draw attention to briefly before I hand over to Joyce was the study on the top right, a paper by Kate Hampshire, who's an anthropologist at Durham, and they applied signaling theory to a question of how patients place trust in physicians working in herbal clinics in Ghana and Tanzania. And what they found is that, and I think this would differ a lot, and some of our survey work has pointed towards this, is that signals that people pay attention to in that environment accord broadly with the local social norms. So for example, church attendance, display of religious symbols, not charging too much. Those tend to be signals that are associated with trustworthiness in these herbal clinics. But what's really important from our perspective is that these signals they have different meaning to different people, what we call receivers in the language of anthropology or biology. Not every signal means the same thing to everyone else, and this is where the problem gets really difficult. If you have a signal like a qualification from an unaccredited institution, for some people, that's a signal of high perceived reliability. And that difference, how you rate that signal, will depend on your level of knowledge around what it means to have a degree from an unaccredited institution. So knowing that the signal depends on the environment, but also depends on the information the receiver has, is key to how you apply signaling theory in questions of trustworthiness in a healthcare context. So I'll hand over. Are you next or Joyce next?
Oh, you're back. Okay, back to Joyce. Yeah, no. So, because I'm just going to pick up on that, I think, to talk about some of the things that we found in work exploring, like how it is that people experience trustworthiness, essentially, through a project which is called TAGGed, which is the Trustworthy Access to Genomic and Health Data project. And I'm going to talk about some of the findings that we had from a series of focus groups that we did. And what was interesting about these focus groups was that in recruiting for them, we asked people what's called the generalized trust question, which is, so it's used in kind of standard social surveys, where it's like, in general, do you think most people can be trusted or not? And so we split the groups between those people who said yes and those people who said no. I'm not going to talk much about the consequences of that split here. I'm not going to separate the data, but what was fascinating was that we did the high trust groups first, and came away from thinking like that did not feel like a high trust conversation. And then we did the low trust groups, and we kind of thought, okay, that's what a low trust conversation feels like, because those situations, I think, as Jonathan was saying, that this kind of importance of the receiver qualities, in which if you go into a conversation with somebody who says, I will not trust anybody at any point, I just do not trust, the signals just kind of start to dissipate, because there are that kind of core group of a group of people who simply do not trust. And we found that previously in work with around the kind of genomic data, where we've segmented populations and found that there are, you have a group of people who will trust everybody, essentially, who will kind of always give their data whenever they're asked, and a group of people who will make those kind of graded decisions, but a very large group of people who will just say, no, I just simply don't trust. So we were interested in understanding in this, moving through from questions of everyday trust. So essentially, what are the situations in which people encounter trust in everyday life, and what are the kind of things that they use in those situations to make judgments of trustworthiness? And then moving from that into some kind of conversations around data and data governance. And I'm just going to give kind of high level overview of some of the things that people were talking to us in these groups about. What is it that they see as being signals of somebody being trustworthy? And the first three groups are actually grouped along these kind of dimensions of competence, reliability, and honesty, but around those kinds of things. That what is it that shows that somebody is competent or capable? And again, I think the things that come up that we weren't expecting, and when we're talking about how do you know you could trust somebody with your data, the respondent who said, well, I think wealth would make a difference. If somebody's wealthy and they're doing well, then it presumably means that to me, it means that they are trusted, that they are trustworthy, and that I could trust them. And they went on to kind of talk. So when we've had that gradation earlier on of where you share data, and then the difference with internationally, for this person, the most trustworthy place to share their data with would have been Dubai, because it was a place that was wealthy, it was doing well, and that for them that was a signal of competence. And so I think it's a useful reflection on the fact that the things that we went into this, and this is kind of always, I think, the joy of the kind of qualitative work, is that you go into things with an expectation that this is what people are going to be talking about. And then somebody will say something like this, and it's, well, we really weren't expecting that to come up as something that was a signal of competence. But then you have more things that maybe more you might expect. So things about, is somebody reliable? So certification, somebody having some kind of check or certificate that, in a research world, having something similar would mean that you could establish them that they were reliable, or signals of honesty, which were kind of very much this idea of this kind of face-to-face thing. But there were other things about how do you know, trustworthiness, like Jonathan said, is this kind of innate thing that you can't detect. So how do you know if somebody's got the kind of character and qualities and virtues that you might think? Well, you might think of other things that indicate that. So for some people, it was things, well, they've got good character, they've got good morals, they might be religious. But for other people, it was a kind of like getting to that somebody's character by knowing them for a long period of time. And again, these are things that are kind of that come across as signals that are quite idiosyncratic at times, but equally that people, what you can see what people are looking for here is these kind of signals that are challenging to mimic or fake. That if you've known somebody for a long time, that's something that's potentially challenging. And then these other things around kind of shared values and the things that people do, or recommendations, kind of trust by proxy. That if somebody trusts somebody, that then you will trust them, that you may trust them too. And that takes us back to some of these kind of questions around health data research, where this feeling that if the NHS trusts an institution enough to share data with them, then if you trust the NHS, then you may pass on that trust. I think what's interesting to me about these is that these are all, so there's a range of things here that are reasons to trust. But they're not necessarily the kinds of things that we might associate with being trustworthy. They're things that are, I think these things like wealth, certification, being able to see the whites of somebody's eyes, religiosity. None of them are necessarily things that you would put in a blanket definition of what it means to be trustworthy. What they are, though, I think, is things that make somebody trustable. They make it possible to place trust in that person. So that these kind of things that are signals of trustworthiness are, in a sense, actually signals of the ability to place trust. But they are only one of a range of things that make it possible to place trust. And this is where I'm going to leave this as the kind of, I think something that we are thinking around at the moment is this kind of question of, well, what is it that creates a situation in which we can trust? So one is the signals of trustworthiness. The other is being a person who is willing to place trust. That idea of, if you are the person who doesn't trust anything, then it's meaningless to talk about trust for those people. But also, and this is kind of relevant as we start thinking about around AI, that the person or thing that is being trusted has to be the kind of thing that is able to be the recipient of trust. In the same way that I can't trust a light switch cannot be the recipient of trust. It doesn't have that element of discretion. And the question is, like, as we're trusting things like AI systems within healthcare, do they have the ability? Are they more like light switches, or are they more like doctors? And how do we establish that? This thing. And then the final thing is that the domain in which we are trusting also has to be the kind of situation in which a trust relationship is an appropriate one. So we've argued this in the case of trusted research environments, which are the kind of, so when we think about the Health Data Research Service, we have the development of frameworks that allow you to keep data secure, monitored, controlled at all times. And then what you do in a situation where you have to, where you control, monitor, and restrict, is that you essentially remove, again, elements of uncertainty and discretion. So you're no longer in an environment in which you are talking about trust. So you may end up in a situation where you can have people who are trustworthy in a situation or context in which that is essentially irrelevant, because there's no ability to place trust within that system. And with that, I'm going to pass on to Joyce to zoom us back out a bit.
So I'm going to take you on a little journey, but before we do, there are two things I'd like for you to keep in your head: signals of trust, which we've been talking about, and mimicking signals. So I want to tell you a little bit about how this collaboration came about. I'm going to explain something called Jakpa and Boga to you, and then I'll tell you a little bit about the accents and trust pilot study that Jonathan and I have been working on the past few months. So that's the Herschel Smith building. That's where this collaboration started. Jonathan and I, up until January this year, were based in the Herschel Smith building, and we actually had desks that were side by side. So we did what all colleagues do in the office. We talked a lot about things that had nothing to do with work, but also about our research projects. And on the face of it, it kind of looks like what we're both working on, they're not related, they don't link to each other. But the more we talked about our work, the more we came up with this little pilot study that marries our interests and our different disciplines. So you've heard a bit about Jonathan and Richard's work. I'm going to tell you a bit about mine. When we go to conferences or when we have to fill in the things on websites and they say, what are your research interests, which I think all of us in this room have had to do at some point, I usually say aging. I say mental health and well-being, especially loneliness and social connections. So I'm very interested in loneliness and social connections in this increasingly digital world, but also because we live in a very global world and people are moving countries, moving around the world. How do we maintain social connections in this kind of world? That's where Jakpa and Boga come in. The P in Jakpa is a KP. So it's a Nigerian word, and the equivalent in Ghana is Boga. I was trying to think about the best way to explain Jakpa, and I thought search engine. So I stuck it in Google, and this is what Copilot says. Jakpa is a Yoruba slang. Yoruba is one of the 3 languages we speak in Nigeria, and it means to flee, to escape. Jakpa is used to describe the movement of people from Nigeria to, some people say, countries in the global north, high-income countries, so to England, to Canada, less so to America because Trump has put us on a list now. But it's essentially the movement of people out of Nigeria. And this could be because they're looking for better economic opportunities, a better healthcare system, better education, security. It could also be that they're looking for a better quality of life. So we don't say migration in everyday conversation in Nigeria. We say Jakpa. So even if you're speaking fully in English, you'll say, oh, she wants to Jakpa, or he's Jakpa to England. We don't actually use the word migration. Now, I'm very interested in Jakpa in Nigeria. The Ghanaian equivalent is Boga, because I wanted to focus specifically on healthcare professionals. What happens when a whole bunch of healthcare professionals leave a global south country to move to a global north country? These are countries that already have fragile healthcare systems. It impacts the ability to achieve sustainable development goals, especially health inequalities. What we're doing with that movement sometimes is we're entrenching existing health inequalities. So I was very interested in that. I was also interested in it from an aging perspective. So like I said, aging is one of my interests. In Nigeria, average life expectancy is 62 for men and 64 for women. So we have a lot of infectious diseases, we have a fragile healthcare system, we don't have national policies around aging. So a lot of the support from older adults, it comes from their children. So when your child is a doctor or a nurse, it's great when they're there, they can help with your care. But when they move and they leave, they're on the other side of the world, what happens? Especially as we don't have any formal healthcare for older adults. So I was interested in it from that perspective, but also because I'm interested in mental health and well-being. The people who have JACBAD, the doctors and nurses in England, in Canada, what does social connection look like for them now? They've moved from very collectivist cultures, they've moved away from their family, and they're now in a different world, a different setup, a different culture. That was my interest. Are you seeing any crossover with Jonathan yet? I like this. So Jonathan had written a book, and I was in the process of writing a book chapter that was about one of the pilot studies I did. We whinged a lot about writing, publication, that whole journey. But in it, we also talked about our work. So for the pilot study, I was working with collaborators in University of Copenhagen and in University of Calabar Teaching Hospital. So what we did in the pilot study was we did dyad interviews. So we spoke to healthcare professionals who had JACBAD, and then we did interviews with one of their parents back in Nigeria. And we asked a variety of questions. The responses you see on screen are from the healthcare professionals who had JACBAD. They talked about a whole bunch of things. They talked about social networks, social identity, transnational care practices, so how they still looked after their parent while they were here, but their parents were in Nigeria. We looked at something called digital kinning, how people still keep that connection with digital technology. They talked about racism, discrimination, talked about feeling like they were tolerated citizens. The countries they were in were tolerating them because of the skill they bring and the service they provide, but they weren't really wanted here. And then they talked a lot about language and communication. Now, I sit next to Jonathan, and I'm finding a whole bunch of things come up about language and communication. In Nigeria and in Ghana, English is our main language. We were colonized by the British system, so all our education is done to a British system. So my participants didn't expect that language and communication would be one of the many things they would struggle with when they moved here. They expected the change in social support, heard a lot about the weather, but they came prepared for that. Language or communication, not so much. And we know from literature that communication is key to building relationships in healthcare settings. I think we can say communication is key to building relationships in any setting. And they talked about how their communication differences led to misunderstandings. I'll give you an example. Choice of words. In Nigeria, we don't say medication, we say drugs. So your doctor would say to you, have you taken your drugs today? It didn't go down so well when they said that in England. And they very quickly realized, yeah, no, they say medication in this country. Those are English words, but the context and the way we use them is different. And that wrong choice of words, try and imagine the nature of that interaction between that doctor and that patient after that. So they talked about how it caused misunderstandings. They talked about, and this was a bit sad, it leading to disciplinary measures. They also talked about how they felt it made it difficult for them to integrate in the team, so be a part of the system they were working with. It made it hard for them to get on with colleagues, feel that sense of belonging in the NHS, and they felt quite marginalized. They also talked about how it made for challenging interactions with patients. I sit next to Jonathan. I'm looking at my findings. I'm not expecting, like Richard said, to see anything about language or communication. I'm telling Jonathan about what I'm finding, and we're thinking, does trust have a component in this? Is the way they speak impacting colleagues' ability to trust them, patients' ability to trust them? So we thought, let's look into this a bit more. Literature tells us trust is a core component in clinical practice. We know that if you trust your clinician, you're more likely to adhere to their medical advice. You're also more likely to report greater satisfaction in the quality of the care you receive. So trust is definitely important in a clinical setting. We also know the NHS is the most diverse it has ever been. It's also the most diverse workforce in the UK. So 18.7% of NHS staff as of 2023 are non-UK nationals. Compare that to 11% of all staff in all other forms of employment. The NHS is definitely our most diverse workforce in the UK. Nigeria and Ghana are the most common contributors of NHS staff from sub-Saharan Africa. Nigeria is actually the third most common contributor of non-EU staff. Ghana is the 8th. So Jonathan and I thought, actually, accents is an important thing to look at here, and we may have a little bit of a pilot study here to explore. We also found that there is existing evidence that international healthcare workers face bias and prejudice based on their appearance. We're going back to signals and trust now. Based on their appearance, based on their name, and based on their accents. I found a lot of things about their accents in my pilot study, and Jonathan and I thought, yeah, let's explore this. So we wanted to see, could these biases, could people's accents reduce trust in a clinical setting? Are they maybe less likely to trust the clinical advice they're receiving because it's in an accent that's foreign to them? Signals and trust again. And going back to the concept of research and data, like Richard was talking about, if the person asking you to take part in a study, asking you to hand over your data, has an accent that's a bit foreign to you, are you less likely to say yes to taking part in that research? So this is what Jonathan and I are doing. I would like for you to think of this as a spectrum. On this end of the spectrum, we've got the doctors in West Africa. We want to get 10 Nigerian doctors in Nigeria, 10 Ghanaian doctors in Ghana to give us audio recordings of the same 3 statements. So we're giving people 3 statements to read. One statement is about genomics. One statement is about vaccinations. One statement is about medication advice. So 5 men and 5 females, because we also want to see if there's a gender thing in here. From Nigeria and for Ghana to read those same 3 statements. On this complete other end of the spectrum, we want to ask 10 native English doctors to give us audio recordings of them reading the exact same 3 statements. Now, in the middle of the spectrum, we want Nigerian doctors who have JAPAD, who are trained in Nigeria but are now working as doctors in the UK. And we want Ghanaian doctors who have BOGAD, who are trained in Ghana but are now working in the UK, to read the exact same statements. Jonathan is going to do some magic with them and stick them in a survey, and they're going out to 2,000 members of the general public. And we want to see how they rate it in terms of trustworthiness of these voices. Now, think about this also in context of the fact that a lot more is online now. You've got digital appointments, telephone appointments. When you hear just that voice, what does trust look like for you in that moment? So again, we're back to signals and trustworthiness. In addition to this, so that this is kind of the quantitative phase of our work. For the qualitative phase, we actually wanted to talk to people, talk to the doctors who have JAPAD, talk to the doctors who have BOGAD, and ask them, our first question, very broad, do you speak differently to different people? No prompts, just that. We want to see what they tell us. Then we're going to probe, what do you change? Do you change your choice of word? Do you change your tone? Why do you make these changes? Are you conscious of it? Are you putting it on? Or are these changes that have happened over time as you've moved here, mimicking signals? Then we want to ask them, why are they making the change? Ask it broadly, and then we want to probe and explore trust. Are they changing their accent? Are they mimicking signals of trust because they want their patients to trust them and they want their colleagues to trust them? Now, because I wanted our participants to trust us, the interviews are being done by people like them. So the Nigerian doctors who have JAPAD are being interviewed by a Nigerian doctor who has JAPAD but is not yet working in the healthcare system in the UK. The Ghanaian doctors who have BOGAD are being interviewed by a Ghanaian doctor who has BOGAD, sorry, Ghanaian nurse who has BOGAD. So someone who also has this experience of, in the literature, it's actually called communication accommodation, the way we change our voices. And really, we want to see if these 14 doctors who have JAPAD and these 14 Ghanaian doctors who have BOGAD, if they can recount experiences of any of the communication challenges they've had and its relation to trust, whether they've actually consciously or unconsciously changed the way they speak because they're trying to build more trusting relationships with their patients and with their colleagues. And that's where we're at the minute. We've got ethics for the UK end of the bits. We are working with Lagos State University College of Medicine in Nigeria, and we're working with University of Development Studies in Ghana. So we've got Nigerian and Ghanaian universities on board to help us pick up the 10 doctors and 10 doctors in both sides. And hopefully this is a pilot study. We might build it into something bigger. I'm going to stop there.